Hello, everyone. Hello. Good evening, everyone. So we'll just leave a few minutes for people to connect. Just started, yes, a couple of minutes earlier to allow people to connect. Excellent. I'm wondering if can someone maybe write down in the chat, in the comment messages, if they can see me and hear me well, please. Okay, some more people are connecting. Can anyone please write a comment beneath the video in the comment area if they can hear me and see me well, please? Thank you, Sarah. Fantastic. Excellent. So the idea is just to wait a couple of minutes more to allow as many people as possible to connect. Thank you, Simone. Thank you very much. Great. I see a few more people are connecting. Thank you all for dedicating your time to this chat this evening. Thank you for sacrificing your time. I know it's 9 p.m. here in the UK and even later in some other parts of the world. It's dinner time, so we all appreciate the time that you take to be here. So my name is Davide. My name is Davide Lanfranco. Actually, I'm a physiotherapist, Italian physiotherapist. I work in London. And I'm a member of FisioScience International. FisioScience International is a platform of a group of Italian physiotherapists who works in different countries, which aim is to deliver and spread evidence-based rehabilitation, evidence-based physiotherapy all around the world. To do this, you can follow us on our channels, YouTube, Facebook, LinkedIn, Twitter, Instagram, and we've launched this series of talk. Today is our second one. It's a series of talk that will run fortnightly. We started 2 weeks ago with Ioneis, and we talked about motivational interviewing and how that can help to deliver pain neuroscience education. And today we'll have the honor and the pleasure of interviewing another great physiotherapist. Over the next weeks, we'll have other chat coming up with other great name on our field that are very knowledgeable physiotherapists. So please stay tuned and stay connected with us because these talks are free. You will have the possibility to interact with the lecturer. So if you have any questions, please write them down in the comment, and during the talk, we'll take some time to answer a few of them. So please, any questions, just at any point of the conversation, just drop a message in the comment. So I think I will introduce you now our guest today. Our top guest is our Irish colleague, physiotherapist Derek Griffin. Derek holds a PhD in pain, and alongside being a brilliant and very knowledgeable physiotherapist, is actually an elite runner as well. So let me add him to the conversation. Hello, Derek.
Hi, David. How are you?
I'm fine, thanks. And you?
I'm good, thanks.
Hello, everyone. So, Derek, would you mind just introducing yourself and tell us a little bit more for the people who don't know you, who you are and what you do?
Yeah, so my name is Griffin. I'm a clinical specialist physiotherapist working primarily in musculoskeletal outpatients in Kerry in Ireland. So it's the southern part of Ireland, and I work as part of the Bon Secours Hospital in my local town, which is a town called Tralee. So my primary caseload is in dealing with people that have a variety of persistent pain conditions. Across various specialities, so musculoskeletal pain, and I also see a large inflammatory pain cohort because I work closely with two rheumatologists who are based in the hospital. So I see quite a varied caseload of people with various pain conditions.
Fantastic. Thank you very much. And I would say we can go directly in medias res into the middle of things. And I would start with the first question. The first question is actually about pain. It is about the new definition of pain by the International Association of Study of Pain. It's been amended after decades for the first time this summer. So I know there has been a lot of talking over the social media about these definitions. Some people were happy with that. Some people were a little bit less happy. I was wondering, what do you think of the new definition, of the new amendments, and if you think that it explained properly the complexity of the experience of pain?
I think the first thing to state there is that it's a really difficult thing to define what pain is. So I think the group that published the paper actually did a very good job on coming up with a diagnose or a definition that's workable and that's that's user friendly both for clinicians and patients. So I suppose just to recap on the previous definition, I believe was from the late 70s, and the previous definition was an unpleasant sensory or an emotional experience that was associated with actual or potential tissue damage. And the primary change in the new definition is that they agreed that it's an unpleasant sensory and emotional experience that's associated with injury or damage, or resembling that associated with injury or damage. And I think that expression that it can resemble that resemble things that are associated with injury or damage is a welcome addition to the new definition. And what that for me does is it really validates the experience of pain among people that have previously been told there's nothing on your MRI scan or there's nothing that we can see wrong with you. And often these people would have previously came away with a belief that they were imagining the pain or it was all in their head. So now we have by definition that you can have what we all know as pain without any specific cause or injury that has been identified on a clinical test or on a scan. So I think it's really important that this, what the definition does, perhaps better than the previous definition, is it just really reinforces that fact that pain is pain, and it is as the person says it is, irrespective of whether the clinician or not can identify a specific pathology or an injury that's linked with that. And as part of the IASP's definition, I think they also linked six keynotes that went with the definition, and I think they teased that out a little bit more in those. So they made it clear that pain is very distinct from nociception. So we know nociception is that sensory input that's coming from the tissues, often at times when there may be a tissue trauma, but nociception is happening in all of us all the time. It's happening when we're sitting for a long time in a certain position, and it's the reason we move around. So we don't develop skin breakdown, or we don't develop a wound or an ulcer, for example. And I suppose the message here is that you can have nociception in the absence of pain, and that's very clear. That has very clear implications for the clinicians in terms of treating the pain, that it's simply not about just what's happening at a tissue level. So I'm pretty pleased with the new definition. I think it's going to be almost impossible to get a definition that pleases everybody, because ultimately pain is what the person says it is. And I think the IASP in their notes agree with that, and they acknowledge that everyone's individual or experience of pain is a very individual one. and that, you know, we can define it broadly, but ultimately it's going to come down to what the patient says it is and their particular experience. And you know, I think the definition allows for that.
I think it's a very good point, Derek. Is a good definition, is a nice definition, and as you said, it is great that they reiterate strongly this message that pain and nociceptions are two different things, and that pain is what the person says it is, because what I witnessed, I don't know you, but what I witnessed still in 2020 is the fact that the clinician knows better than the patient. They knows better how much pain they should experience, how much pain they should be in, according to MRIs, according to clinical tests, and that is always very, very sad to see.
Yeah, absolutely.
So I hope this definition will help a little bit of clinician of changing their perspective. So this summer, alongside this new definition of pain, it came out for those who live in England, but say affects people all over the world. They drafted a new version of the guidelines for the treatment of primary chronic pain. And that draft came out, again, on the social media. I've seen as well on patients suffering from chronic pain on the various social media were quite shocked by it and by some of the conclusion it made. So I was wondering, first, what do you think of that, if you can summarize it for us? But first, if you can clarify what primary chronic pain is, please.
Yeah, I suppose I was a little surprised that in terms of NICE's publication that they specifically targeted primary chronic pain. It's a very new definition. It's a very recently introduced definition, and I'm not sure we've had it around for long enough to really, you know, to produce a guideline specifically around what based on primary chronic pain. So the as part of the International Classification of Diseases in the 11th edition, so they proposed a new classification of chronic pain disorders. And at a very gross level, they classified it into primary chronic pain versus secondary chronic pain. So I'll talk about secondary chronic pain first, because it's probably something that's easier to define. So secondary chronic pain is pain, as the label suggests, it's secondary to a known cause. So that might be an injury or a specific pathophysiological issue that we're aware of. And I suppose the typical examples there would be something like inflammatory arthritis, where there's a known disease process and there's pain associated with that specific condition. And then primary pain is really an umbrella term for persistent pain problems where there's no readily identifiable, you know, source of peripheral nociception, I suppose. So there's no specific injury we can identify or a peripheral pathology that would better account for the pain. So, you know, I think there are some issues with this distinction. I think first and foremost, the reason that it was proposed, again, is going back to my point earlier, that primary chronic pain kind of validates the patient's experience when the scans and all the tests are often negative. You know, so I suppose for the first time now, that we don't see pain always as a symptom of something else, that pain can be the problem in its own right. And I do think that's one of the benefits of the primary versus secondary pain definition. And I think that was probably at the back of the researchers and academics' minds when they were proposing these various categorizations, that we need to somehow show that you can have pain and it can be it can be classified as a condition in its own right, even when we can't identify another specific reason for it. So it kind of gets around this whole previous notion of physical versus psychological, or, you know, mind versus body. It kind of overcomes that and says, you know, basically pain is pain, irrespective of whether we can find a particular disease or a condition that will explain it. However, I do think we run into a little bit of problems, as with any classification system. So it's very difficult in the clinic for me to put a patient into a nice neat box of primary versus secondary. And I suppose I'll give you two examples that spring to mind that kind of illustrate that. So if we take somebody that has rheumatoid arthritis or, you know, another autoimmune inflammatory condition, we know that, yes, inflammation is a potent driver of pain. However, we also know that in people with very well-controlled disease, they can continue to have persistent pain. So here we have a scenario where the pain is defined as being secondary to the condition. Yet when the condition is very well controlled and the blood markers of inflammation are normal, the person continues to have persistent pain. And we know that approximately 60% of people with well-controlled inflammatory disease on a biologic drug have persistent pain. So the question now arises is the pain still secondary to the inflammation, or is there now a component of so-called primary pain because we've controlled their inflammation and yet they're still having pain? So again, it's one example of where you can't simply classify them as one or the other. And my concern about something like that would be that we would assume that if we treat the underlying pathology, or if we treat the inflammation, for example, through medication or various other means, that the pain would simply go. And if it doesn't happen, then we run out of options. And that's simply not the case. So, regardless of who we're treating or what condition that we may have, we need to realize is that there's always multiple factors that contribute to pain. And that's always going to be more than just the disease process when it is present. So I'm not sure that we can always say, even when there is a clear disease process, that there is never a pain component that might have developed, yes, secondary to the problem initially, but now has become a problem in its own right. And we run, how do we classify this kind of mixed presentation? And then another example would be, as part of the new classification system, a condition like fibromyalgia is now considered to be a primary pain problem. However, a trial recently, not a trial, but an observational study that was published, I think it was 2019, took a group of people that met the criteria for having fibromyalgia, and they looked at the response of their pain following a joint replacement. I think it was a lower limb joint. These people were scheduled for joint replacement, and it showed in about 1/3 of these patients that their symptoms of fibromyalgia significantly improved after having a joint replacement. Now, one of the explanations for that, or one of the interpretations, I suppose, is that in a percentage of these people, the widespread symptoms and sensitization was perhaps being maintained by something in the periphery. So these people that would, by definition, be categorized as having primary chronic pain, again, that idea that these people improved with a peripheral intervention suggests actually that there may have been a peripheral component or a driver of this that wasn't necessarily readily identifiable from just based on knowledge of their pain alone without a clinical examination. So the trap that we could fall into is just assuming it's one or the other, and that will inevitably bias the clinician in one direction or the other. And I don't think that's fair. I think we have to see everybody as an individual. So if someone comes in and, to me, and they have widespread pain that meets the criteria for fibromyalgia, by definition primary pain, that will not deter me from looking at, is there any clear peripheral driver or that might be at least a contributing factor to their problem, rather than seeing it purely as a primary pain condition that has nothing to do with issues in the tissues or any peripheral input. So, I think the danger is that we become biased in our classifications of primary versus secondary, and we lose sight of the patient in front of us. And that's always a potential problem in the clinic.
I think you said so many great things, Derek, that really we could do other 10 webinars on what we have just said over the last 3 minutes. And I think it's great because, again, with this putting people into boxes, with this labeling everyone, we fall back into the biomedical model again. We lose the patient at the center of our treatment. We go back to this dichotomy, this versus that one. Absolutely. And even I was wondering, for us physiotherapists that we don't prescribe drugs or we don't do any more invasive treatment, what is the utility of knowing for sure if it's neuropathic pain compared to nociplastic pain compared to fibromyalgia pain? How useful is that in terms of treatment, if that is the unicity of the person at the center of the treatment?
Yeah, I think there's, for many years we have looked at mechanism-based approaches to patient care. So the three primary mechanisms that would spring to mind would be nociceptive pain, neuropathic pain, and a recently introduced concept of nociplastic pain, which is again pain that's not attributable to any identifiable neural or non-neural tissue lesion. And again, if we're not careful, it can become a very reductionist approach. So if we classify people as, nociceptive or neuropathic or nociplastic, in and of itself, that tells me very little about the patient. It tells me very little about what I can actually do to help these people. So, while knowledge of pain mechanisms is important, it really is only one part of a bigger picture. And what's more important is that we listen to the patient's story, we understand the various factors across the various domains, the physical, psychosocial, environmental, lifestyle, genetic, all of that, various bits of the puzzle that may have contributed to their experience of pain. And ultimately, when I'm designing a rehab program, that's what helps me in terms of what I can change, rather than labeling them as neuropathic or nociceptive or nociplastic, because I'm not aware of any really good research that tells us that when we classify people into these groups and we treat them accordingly, that we necessarily get better outcomes. That really hasn't been shown. It's a very theoretical assumption that has very little empirical backing. And again, my concern, as always, is that it becomes a recipe approach. So we think of somebody that has, features of central sensitization or nociplastic type pain, that we have a preconceived notion of what we should be doing with that group, versus if it's somebody with where there's a very clear tissue driver of the symptoms, that it becomes rather, a little bit focused on the mechanism rather than the person. And we have to consider the person in any classification system we're going to use.
Absolutely. That's fantastic. And going back to the draft of the NICE guidelines on primary chronic pain, the conclusion, the summary of these guidelines was that the first line treatment is exercise coupled up with ACT or CBT for the psychological therapies, and then it closes the door to drugs, so anti-inflammatory drugs, to paracetamol, or to heavier drugs as well. And but very curiously opens the door to acupuncture, as long as it is done within a certain limit. So that left a lot of people puzzled. What do you think about this?
Yeah. Again, I suppose I commend the team for trying to. It's never an easy guideline to put together. When you lump all of these various conditions that comes under the umbrella of primary chronic pain, it's a real challenge to come up with a workable document that's useful in the clinic. To me, look, as a physio and as somebody that is particularly interested in health promotion, I value their recommendation around active treatments, particularly around exercise and interventions that enhance self-management and self-control. And this is where the psychology interventions come in. Their recommendations on drugs. Again, I'm not a pharmacist, or I'm not as familiar with the pharmacology literature as I would be with the non-pharmacology management. But I suppose what's interesting to me is that if we look at, for example, if we look at the low back pain literature, or if we look at any kind of specific chronic pain condition, when we examine the evidence, if we compare a physical versus a psychological versus a pharmacological intervention, the effect sizes are relatively similar. So, I think the emphasis on the guidelines was probably looking at interventions that are readily accessible, that may be less harmful in some ways to patients, especially in the long term. I think what they might have missed out in, though, is that if you're somebody that has had chronic pain for a long period of time and you have been taking prescription medication, these guidelines are going to come as a real big shock to you. Regardless, we can argue about the efficacy of the drug management, and we can talk about, well, the evidence isn't very good in terms of outcomes, so therefore the guidelines were correct in not recommending these. However, that if we're going to promote more self-management approaches to pain and active approaches based on exercise and psychological therapies, then there needs to be a lot more resources in place, a lot more educational resources, access to these services. Where does the patient go to get them? Are there established pathways from the GP in primary care to access these services? So, the document on its own can be, we can appraise it from an evidence-based perspective. But how do you implement that at the ground level, and is a very different question. And we need to be careful, because the media reported on the NICE guidelines, and we have to remember this is a draft NICE guideline. I'm not sure has the final document been published yet, but the media were quite. It's interesting how they portray what the document actually showed, and a lot of the headlines were around NICE dismisses medication and promotes physical and psychological therapies, and this immediately among people with pain on Twitter and social media brought up things like, oh, are they saying it's all in my head, or I just need to cope with the pain better and I don't need medication? And this is where we lose the patient. So we really need to be a little bit more aware of how we communicate science and how we communicate the results of these kind of documents with the general public, so that we don't alienate them. And this looks like we've just taken away an intervention that they've been using, rather than looking at how do we educate them and how do we change their beliefs around what some of these interventions offer. So there's pros and cons to it. Again, like I said, they did very well in putting together such a big body of evidence, but how well this is going to go down with clinicians and the patient groups is going to be a challenge for sure.
Absolutely, I think it's a very good analysis. And moving on to next topic, you've published a list of do's and don'ts of persistent pain. And for the people listening to us, if you have not read it yet, please go and check it out on the Griffin accounts on Twitter, on Facebook. You can easily find it. And it's a very, very great list full of very good points. The first point, the first don't, you state to not blame yourself, of course, refer to the patients, to not blame yourself nor fight pain. And that is a very good thing, because when I work with people with persistent pain, what I sense, what I understand is that somehow there is a blaming component. They think sometimes they are not good enough to overcome the problem, to tackle it, and they refer to themselves as useless or not good enough. Yeah. What would you do to support the patients in following in this tip? Because saying is one thing, but then how do you help them to develop this awareness?
Yeah, so I think the first thing that we must do is we must validate their symptoms. We must, readily accept that their symptoms are real at whatever level they say it is. So it's not my place to interpret how much pain somebody should have based on what I can find in the clinic. And this is where the concept of stigma has arisen. So many patients basically feel that they have to be seen to be tough and brave and not to be, not to succumb to pain. And there's a public perception that, they've seen nothing wrong with your MRI scan, and there's nothing wrong with you. You just need to toughen up, and you need to persist with that. And I think patients, sometimes they spend a lot of effort trying to tell a clinician that, that they're working hard, or they're having to they're pushing up with a lot of pain, and they're pushing through it because they think that that's what we want to hear. They think that that's what makes it, that's what they should be doing. And that's a very difficult place for these people to be, because, we know that this kind of endurance coping ultimately will be maladaptive in the long term. So these people often, can persist with an activity that results in routine flare-ups, and they're relying heavily on prescription medication, including opioid medication, just to be able to so-called fight the pain or battle the pain. So we absolutely need to drop all of these metaphors around, fighting pain and being tough. And a lot of this comes from other domains, like, athletes, for example. You have to be seen as tough, and everyone is amazed about the athlete that fights through the pain and just, is being brave. And we need to drop our egos, leave our egos at the door when it comes to helping people with pain. It's absolutely fine to validate their experience and validate how they've coped with it. So it might not be the way that we want them to cope with it, but ultimately that's the way they have been coping with it. So while I might want to change that, we absolutely have to accept and validate to them that this is okay. I can see how you ended up doing this, or why you're doing this, rather than telling them that, this is wrong and you shouldn't be doing it this way, and you need to do it this way. We have to see the patient at a human level, that when they're in pain, it can be very difficult to kind of problem solve their way out of it. And clinicians at times can inadvertently blame patients without necessarily meaning to do that. So when we talk about things like the role of exercise and the role of sleep, it can sometimes come across to them as you have pain because you're not exercising enough, or you have pain because you're not sleeping enough. And that sounds like we're blaming them for their own problem. But how much exercise they do and how much sleep they have is entirely dependent on their life circumstances, on the broader social factors. So sometimes these are not simple choices. Some people, it's not a choice always to how much exercise you do or how much sleep you have. There are a lot of social factors that have a strong implication for these so-called behavioral factors. And, clinicians need to be very much aware of that. And one of the areas that we see this an awful lot in, and, we see it in social media, we even see it in the research, is this idea that if the patient isn't getting better, then they must be not compliant with my program. They mustn't be doing their exercises 3 times a day, and they're not doing enough repetitions. Another explanation for that is that they're not doing it because it doesn't work, or it's not working. So it's not necessarily the patient's fault. The clinician needs to ask themselves, well, why aren't they doing my exercises, or why aren't they doing my program? And the answer to that might be that because it doesn't meet them at their level. This isn't person-centered. This is, this is almost, it's more recipe-based. It's not aimed at that individual. And for example, as part of my PhD work, I did a qualitative study looking at people with chronic low back pain, their beliefs around activity and exercise. And there was a variety of different opinions on the whole topic. But many people reported being prescribed swimming, but their nearest swimming pool was 30 miles away, and they had no way to get there. And in order to get there, they'd have, it'd take an hour to get there, then an hour home, and they'd, do a half an hour swim. People can take 2.5 hours out of their life to do that. So the clinician needs to come up with an alternative way of implementing or introducing exercise into someone's regime. So it's a complicated question, David, but we really need to meet the patient at their level and give them permission that it's okay to show pain. It's okay to express pain in whatever way they want to express it. We're all individual. We all have different ways of coping with things. And then my job as a clinician and any clinician is to take them on a journey that might develop different ways or different perspectives or different skills in how to manage that.
They're very great words, Derek. And I see this every day. I listen to this from my patients when they come and tell me, I went to see another physio. He gave me 2 sheets of exercises and he told me do them every day, twice a day. And he says, when do I have the time to do this? I have kids to look after, or I work in the city of London. They work 15, 16 hours a day. When do I have the time to do that? I cannot not work, because otherwise my career will fail. So what do we do as physiotherapists to put the patient at the center of the therapy? Because otherwise we keep falling out of the biopsychosocial model, and we just put people into boxes and we give them stuff to do. And if they don't get better, that we wash our hands and that's their fault. It's not like that.
I think the biopsychosocial model isn't simply asking people questions about, their mood and their sleep and their general well-being. It's actually using that information in a very integrated way when you're putting together a plan for them. So ultimately, it's about how do you use that information both as a way of giving them insight into their condition, but then as a way out of it as well. It's not simply a data collection tool.
Again, you described very well the problem with the biopsychosocial model. Is just people maybe ask the questions, look for yellow flags, but then they don't know what to do with them, and they don't know how to fit them for the patient. They don't know how to create a treatment based on that. So
I agree.
That's an excellent topic. And always on your list of do's and don'ts, you raise another excellent point. You say to the patient, don't rush or panic if pain flares up. And that is a very interesting thing, a very complex topic, especially with people with persistent pain, because they see the flare-up as a defeat. They see the flare-up as, I'm back to square one. And that what throws them into desperation is the fact that it seems like that all the work we've done is lost. So how do you guide them into the awareness that a flare-up is something normal, and what strategies do you give them to face them?
So education is your biggest is the biggest thing that I would do with them, but I would do it from the very, very beginning. So, as the first time I see these people, and when we're kind of discussing the concepts around their rehabilitation plan, I will talk to them about the likelihood of having what they might have previously considered setbacks, and what I might try to get them to redefine or reconsider as a kind of a slight detour in the road. These people will generally come into you. They'll have a history of flare-ups of different intensities, durations, and frequencies. Everyone is different, but ultimately most people will have had times where their pain is exacerbated that significantly impacts on their function. So realistic expectations from the very beginning, and preparing people that flare-ups are not uncommon. So I'm not telling them that it will definitely happen, but the reality is, and clinicians need to accept that reality, that it's quite likely that it will happen. So when people are prepared and they don't see it as something that's unexpected, they generally can cope better with it. And the precise flare-up plan, as I might call it, would be different depending on that individual. So I suppose I would look at previously how they deal with a flare-up. So if they've previously been very passive and rely solely on medication and more passive interventions, then we might look at other active strategies that they can use going forward. And that's depending on what they like, what their hobbies are, what resources that we have available. And something that's really important is that they have access to you as a clinician when they do flare up. And whether that's a quick phone call, whether that's an email, for example, we know that social support and just that little bit of reassurance can go a very long way. And people need to know that they have someplace to ask a question if this happens. So I suppose simply put, my advice to clinicians out there would be to talk with your patients about this at a much earlier stage, and don't just wait for the flare-up to happen, because that can be a little bit more of a challenge than if you have them prepared for that.
So would you say actually a flare-up is going to come and discuss like if it is a certainty that flare-ups arrive?
Yeah, no, I won't necessarily say it'll definitely happen, because I don't know that. But I, again, based on what we normally see with these conditions, that it's definitely not uncommon. And if it does happen, here is the plan. This is what we will do. We'll monitor the outcome of that, and then we'll use that information going forward for the next flare-up. And hopefully over time, the flare-ups become less frequent, less intense, and better management. But I do strongly believe that how somebody manages a flare-up has a big influence on their longer term outcomes and the trajectory of their pain. That's not captured very well in the literature, because most randomized controlled trials would look at 3, 6, and 12-month data, for example. We're not actually seeing what's happening in that middle, say 3 months is a long time. And if a patient has had 2 flare-ups in that 3 months and that they're not coping very well, that's going to impact their ability to sustain any improvements. Whereas if we implement better flare-up management plans or strategies, it would be really interesting to see, do we change the long-term outcomes? I can't say for sure that we can, and I get it's a very difficult study design to do. You'd almost need I suppose it's more of a kind of a case series or a case series design, because you need very detailed information, over a long time frame to kind of capture that. But I definitely think that's a worthwhile venture.
Absolutely. And moving to the next topic instead, I want just to discuss with you about exposure therapy. Yeah. Could you tell us a little bit what it is, what literature says, and how it can be helpful for a clinician?
Yeah, so exposure therapy is an intervention that has its roots in the psychology literature, so for various phobias and anxiety disorders. And, first and foremost, exposure therapy is primarily aimed at reducing disability or reducing avoidance behavior. Now, people with pain avoid movements for many reasons. It may be fear and belief driven, so they may have a belief that a certain movement is dangerous or that it's going to result in a pain flare-up, for example, and they avoid it. Or they simply might avoid it because, that they avoid pain. So it may be fear or belief driven, or it may be that they're just not moving in a direction of pain because maybe of an underlying belief that, pain means damage, and therefore I need to avoid pain if I'm going to protect myself. So, exposure therapy really, I suppose, is taking pain education that further step. So we can educate people that pain doesn't always mean damage, and exercise and activity are safe even when you have pain. However, that's just information if it's not put into practice. So exposure therapy really gets patients engaging with movements or tasks or contexts or situations that they have avoided for whatever reason, and exposes them to these environments or activities over a period of time with the aim of reducing their functional disability. And what we're starting to see in some of the recent literature now, there has been, in the last 2 or 3 years, we've seen trials in 2 very complex groups of individuals. So one group was people with complex regional pain syndrome, and the other group was people with fibromyalgia. And in both groups, we saw a reduction in disability, but we also saw a reduction in pain. And I suppose, I don't know if you know my work in the area, Devi, but I'm a strong believer that we shouldn't be just looking at change in so-called function and disability. That there is value in looking at pain from whether we're talking about pain intensity or the quality of the pain, or but we need to be looking at changing pain as well as function and disability, because while there's not a one-on-one relationship between how much pain you have and how disabled you are, we'd be naive to think that they're completely independent as well. So I think that we'll see a lot more work in the next few years looking at these more behavioral interventions around exposing people to activities or tasks that they've avoided. And it'll be interesting to see the data that emerges, particularly around actually can we change pain as well as disability if done for long enough, and if we can really engage the patient into why they're doing it. So there's a real area to develop there of, if we combine our education strategies around pain with the second bit, which is the behavioral side of things, and we can really get them to take on board everything they've learned about pain and put that into practice through facing their fears, I suppose, I think there's really good scope for improving outcomes if we can achieve that.
Yes, thank you, Derek. And that actually raised a very good point that made me think about something. There is, in acceptance commitment therapy, they say that actually the focus of the treatment is more on the getting you back to a full life and not on the symptoms. And that they say eventually in the process of doing so, symptoms will decrease. And yes, there is, from one side, there is an over attention from certain medical professionals to tries to tackle pain at every cost. But on the other side, we may lose the opportunity of giving some pain relief to people. As you said, the pain relief is something we should follow. So when do we draw a line? When do we say enough is enough? And when we draw a line to the patients according, you've done already too much, now it's time to focus on something else, or we carry on looking for solutions?
Yeah, I think as you just mentioned, the sole treatment goal should never be just around pain. And, we should be very careful that we don't give patients unrealistic expectations around, you will definitely have a reduction in pain, or you will have a reduction in pain by 50%, or we give them the illusion that they may be pain-free. And I think often that's, that's not fair, because we don't have the data that shows that. However, we also need to be aware that we don't condition the patient to believe that your pain is not going to change because it hasn't changed in 10 years now. Therefore, we should just focus on your function. And the reason I say that is because we know that expectation has a strong influence on the pain that we experience. So, if the expectation is that this treatment will not change my pain, we actually increase the likelihood that it won't change their pain. And we have good evidence around that expectation plays a really strong. It can play a placebo role, and it can play a nocebo role. So it can make you better or worse depending on that explanation. So I'm quite open with patients that looking at changing pain may be a goal, but it's not going to be the sole aim of the treatment. And I think there's value in some of the concepts that people that use acceptance and commitment therapy offer, because there is an emphasis on you can function despite having pain. So we break that barrier between pain means I shouldn't move or I shouldn't engage in things that are of meaning for me. But the reality is, when we look at the data, and there's a recent Cochrane review looking at all the psychological therapies for chronic pain, acceptance and commitment therapy as of yet, and it's probably it hasn't had as many years of research compared to more traditional models of CBT. But the reality is that the data is not any better compared to other forms of CBT. So while the narrative around improving function and taking the focus away from pain and almost de-emphasizing cognitive restructuring and changing beliefs, the reality is that the outcomes are not necessarily better from other interventions where pain may have been a focus. So we do need the data to back up a lot of the I suppose the claims made around acceptance and commitment therapy. I do use it a bit in terms of the concepts. I do like the concepts that it talks about psychological flexibility and functioning despite pain, and value and meaningful activities, and separating your thoughts and your beliefs from your actions. And I think that's really, really good. But we just need to be careful that it doesn't become this thing that we assume is better than all these other things without the data to support that. So I would just encourage the clinicians to keep an open mind, read widely.
Oops, I lost you, Derek. Could you guys, people, let me know if you can still hear me and see me in the chat, please? Okay, 1 second, sorry, let me sort out the issue. Can you hear me and see me, guys? Fantastic. Yes, Derek is frozen, so I assume is a problem from his connection. So please bear with us a couple of minutes and we'll get him back. Thank you, Danny. Okay, we'll try. So yes, he's frozen, he disconnected. I think he has a problem with the connection. So we'll wait a second for him to get back to us. Thank you anyway, guys, for spending your time listening to this chat. I think very, very good points has been raised so far. So I hope you find this useful. Okay. Let's see if we can. Just bear with us a couple of minutes, please. Okay, I've sent him another link, so he hopefully will join us soon. We still have a few things to discuss together. Frozen camera syndrome, says Ethan. That's a nice one. I just encourage you, if you have any questions, please, on what we've discussed so far, and especially maybe on exposure therapy. If you have any question, to please drop it so we can answer it live eventually or answer it later. Oh, here we go.
Can you hear me?
Yes, I can hear you.
Sorry, I lost internet connection.
That's fine. Ethan suggests this is called frozen camera syndrome. They're writing on the comments.
Okay.
Anyway, sorry.
You're okay.
We were discussing about exposure therapy and about pain reduction when you left us. So I've actually, please carry on.
No, you're okay. I'm just trying to set up. I'm using a phone now to try to.
So what you said before it makes me wonder about another question. The type of exposure CBT and ACT recommends is pretty different. CBT is more of an exposure, just do it gradually, graded. ACT instead is do it mindfully, so be conscious of your experience. When you provide an exercise to one of your patients with the intent of decreasing their kinesiophobia, where is the focus of the exercise? What do you tell them?
Yeah, I think you actually, one of the key concepts of effective exposure therapy is actually to get the individual to very much be aware and focus on what they're doing, because if you use a lot of distraction techniques when you're getting people to do these kind of interventions, that ultimately, like, distraction actually becomes an avoidance strategy, so they're avoiding the situation at hand, or they're trying to, they're trying to disengage with it, and that's not effective in the long term. So I suppose it's really important that, we'll just say, for example, if it's an individual with low back pain, and the exposure intervention is around a bending task or a lifting task, a simple strategy would be to get them to talk through their beliefs and their their feelings and their emotions as they're doing the task. So to really get them to engage and to express, oh, I'm really fearful, I'm really scared of this, I'm worried that something will happen in my back, or whatever it might be, and therefore, that can become an effective way of, I suppose, really engaging people in the task that they're doing, and trying to then create this mismatch between what they expect will happen and what actually happens. And that's a real powerful driver of learning, and over time, hopefully, then would result in less avoidance behavior and more engagement with the task. So I'm a big fan of really getting them to engage with what they're doing, talk it through, use your motivational interviewing techniques, use all those skills that you've developed to really try to drive the good outcomes.
Yeah, I think it's very important as well, just not to do those exercises mechanically, but to engage with the experience in the present moment. And then actually the questions in the comments from Paulos asking what's the difference between graded exercises and graded exposure. And before asking you the question, sorry, Derek, that reminds me of a paper I read recently in which they say that graded exercise, graded exposure, there is not much difference in terms of outcome. What do you think?
Yeah, so graded exercise is exactly as what it says. It's really just looking at an exercise task, whether it's walking, cycling, swimming, gym, whatever it might be, and building it up in a gradual and a progressive manner. However, there are many people that have a pain problem that exercise and still avoid certain activities. So there, for example, they might go for a run, or they might do a squat in the gym, but they won't pick up a heavy box off the floor, for example. So exposure therapy is very specific to tasks that people avoid, and that they're avoiding either because of a belief that it will make them worse, or they have an experience of pain when they're doing it, and that they're avoiding the pain. You're right in what you're in mentioning that paper where they showed the very little difference between graded exercise and graded exposure. And again, that's what the data says, so we have to accept the data. But going back to what I mentioned earlier, as a clinician, and what I would like to see, I suppose, being tested in the research, is that when we combine the exposure with a really strong understanding of what pain is, and the educational components around pain neuroscience. And I know you had Joe Nige on last week, or 2 weeks ago, that kind of delved into that in more detail. But when you really change their fundamental beliefs around pain, and then you expose them to various things that they might have avoided or hadn't been doing, and you make those tasks very specific to them and to the things that they want to do and want to be able to do, perhaps we can achieve better outcomes when we do that. So it is very much a work in progress, and we have to be led by the data. So it'll be interesting to see where the field goes with this. But some of the recent work, as I mentioned, on complex regional pain syndrome and fibromyalgia is promising. And interestingly enough, both of those groups, both of those papers, used a rather, I suppose, an aggressive approach to exposure therapy, where they really looked at exposing people to tasks despite the presence of pain, and the outcomes were favorable. So I think it's a promising area.
Thank you very much. And so that leads us to our last question, I would say. And then if you have people listening, if you have any other questions, please write them down. But otherwise, the next question I was going to ask you is, in the light of what we've discussed about exposing the person to fearful movement, fearful situations, scary situations, scary movements, activities, why exercise is effective? Why is exercise helpful in patients? Is because we actually condition the body and the tissues, or because we somehow tackle the fear and we expose?
I think you know all of the above. There's multiple mechanisms by which any intervention can result in less pain. Now, like let's be clear in terms of exercise. When we look at the research and the systematic reviews, while exercise is we know it's beneficial and it does have a pain relieving effect. Unfortunately, the effect sizes are nothing too special compared to any other intervention. So exercise is a part of a broader behavioral intervention, but I don't think we can say yet that exercise on its own is enough to we need to be doing better. But in terms of the mechanisms that why exercise works, the neurophysiological mechanisms are quite complex, and I would refer the listeners to a recent paper. I believe it was published in one of the pain journals. It's either the primary pain journal or Pain Reports. It was a review by Professor Kathleen Sluka, who is one of the leading world experts on exercise-induced hypoalgesia or hyperalgesia, and looking at the mechanisms that underpin it. So from descending inhibition to all these various neurophysiological phenomena that can result in pain relief, but then other phenomena as well, like expectation induced pain relief. So we can't discount the role of these contextual factors. If exercise is performed in a social setting, there may be social benefits, more social interaction, motivation, support, and that then has an impact on pain relief. And of course, with any intervention, there's going to be so-called placebo effects as well. So I think exercise has very broad health benefits. It's something that, as people that should be promoting health in general, among the community, not just in patient populations, I think there's an onus of responsibility to encourage these people to get more active and to look at ways of incorporating exercise into their lives. And I suppose the final thing I would say on that is that we also shouldn't assume that everybody with persistent pain is inactive. There is a group of people that are very active and continue to live very fit and active lifestyles, and yet continue to have pain. And I suppose that reinforces my point that it's not, we simply can't exercise our way out of pain, but it definitely helps and as part of a much bigger, broader intervention.
Thank you very much, Derek. I think there are so many take-home messages here, so many important things that you've said over the last hours. So I encourage people to that you can listen again to this chat we just had. It stays on our social media channel. I've seen there are some questions coming up, Derek.
Okay.
So I will put them here. Can you read it?
Yeah, I just have to lean in to see because I'm reading it off the mobile. Where do you feel manual therapy falls when addressing pain and working with patients? Look, okay, I suppose my beliefs on manual therapy are probably well known at this stage. I don't use it as part of my as part of my daily clinical practice. That doesn't mean that I don't feel that touch is a powerful modulator of pain, or that it's an important part of our assessment. So where I feel kind of manual, I suppose I'm not going to use the term intervention, but manual assessment techniques fit in. It's really as part of a comprehensive assessment that we can show the patient that we've done a thorough examination. It gives me a good insight into their overall sensitivity. So whether they've pain in a very localized, discrete area, or whether they have more widespread sensitivity. But I suppose in terms of its use as an intervention, people know that if we look at manual therapy versus other forms of activity, for example exercise or any other intervention, that we generally have comparable effect sizes across these interventions. And look, I suppose my preference is to use more of these active interventions. I don't believe the evidence is strong enough to suggest that when we put interventions together, so the argument will be that if we combine exercise and manual therapy, that we get better effects than if we just use one or the other. And I'm not convinced there's not a lot of consistency in the literature to answer that question. So, again, my preference would be to use more active-based interventions. But I suppose I am biased, and to a certain extent, by the patient populations that I see. So I generally see people that have had all that type of intervention, that have, most of my patients will have more widespread symptoms. They'll have had a lot of manual intervention. They'll have had that already, and they won't have had successful outcomes. So, I suppose my role is to look at a different perspective and a different way that we can view that. So I think it's very much dependent on the patient population and the setting that you work in, because that will dictate primarily what you're seeing in the clinic. And I do wonder at times, is that why, clinicians can often seem to have very varying beliefs on a particular topic, because ultimately we're probably seeing different clinical populations in the clinic, and that obviously has an impact on our own beliefs as well.
Thank you very much, Derek. That is always a tricky questions about manual therapy, and thank you, Derek, for asking it. There is one more question if you have
Okay.
time, Derek.
Yeah.
From Peter is asking, how big of an obstacle is depression in people with chronic pain for rehabilitation, would you say? And if you don't mind, Peter, I would add that lots of people say, is depression causing the problem, or is the problem causing depression?
Yeah, and that's a very good question, Peter. I think we know that, having depression is both a risk factor for pain, but we also know that if you've had pain for a long period of time and it's significantly impacting your work and your social relationships and your function and your social roles, then that unfortunately can lead to a higher likelihood of depression. Untreated depression, or a significant level of depression is by, I have no doubt that it's a strong barrier to recovery, and we see that in the clinic all the time. So as a clinician, clearly we're physiotherapists, so we're not trained, nor should we be looking at being the primary providers for people that have a diagnosis of depression. But this is where you need to have depression you need to know the signs and symptoms that you can recognize in patients. And there are a number of screening questionnaires, for example, that we can use. And where this might be an issue, or where, particularly in people that have untreated depression or haven't consulted their GP, for example, it's important that we have the discussion with them and look at encouraging these people to engage with their primary health provider, which is usually their GP, and just start to open up a discussion on how better we can manage their mood issues, or it may not be depression, but they still may need more specific intervention. So I suppose identifying the signs and symptoms and then referring on is important. And something that I talk about regularly, and as physios, we hear talk about red flags a lot. So we're at undergraduate level, where we're taught to recognize signs of infection, for example, or signs of malignancy, or signs of an inflammatory disorder. And something that I would encourage people to start to think about is like, well, why aren't we encouraged to spot these other conditions that might be, that might equally warrant further investigation or follow-up, such as depression? So I think we need much more awareness of it as clinicians as to the signs and symptoms, and we need to see it as part of just people's general health and well-being, and there needn't be the stigma that sometimes can go with asking questions about these conditions. So a clinician might be very comfortable asking somebody about their medical history in terms of, have they a history of diabetes, or have they a history of cancer? But we mightn't ask somebody, have they a history of anxiety or depression, for example? And that's often, because maybe the clinician is a bit worried to ask these questions. They're sensitive topics. And we need to start to break down the barriers. That shouldn't be the case. We should be able to talk about mental health and depression just like we will talk about cardiovascular disease or diabetes, for example. So, I think we need, as clinicians, to assess how we assess for these conditions and have supports in the community and multidisciplinary team that we can refer people to when we're concerned that something else might be impeding recovery, and being very open with the patient and having an open discussion with them about that.
Thank you very much, Derek. I think is I really couldn't agree more. I think anything I would say is redundant. So thank you very much for this, and thank you very much. Thank you very much for being with us tonight. It's been fantastic. You really delivered a great amount of stuff, and for everyone who didn't manage to listen today, we have the possibility again to listen it on our channel on YouTube and on Facebook. And Derek, last thing, how can people reach out to you? How can people contact you? I know that you are very active on social medias.
Yeah, so I suppose the easiest way to get me is I'm quite active on Twitter. So my Twitter handle is at Derek Griffin 86. I'm also on Facebook at Dr. Derek Griffin Physiotherapy. And of course, I'm happy to take any questions by private message, or my email is derekgriffinphysio@gmail.com. So I'm happy to take any topics that anyone maybe wants to discuss a little bit further, or just tease out a little bit more. So I'm happy to do that.
Thank you very much. So before I'll say goodbye, I'll just remind you that over the next weeks we have other chat coming up with Ben Cormack is the next one. So please do stay tuned, and because much more is yet to come. So thank you very much again, Derek, and good night. Good night to you all, and thank you for listening.
Thanks for having me.
Bye.
Bye. Bye.
Thank you all for being here and listening and giving us your time. Thank you very much. I know it's late,